unless you're interviewing, like, they just like you, they don't.
Yeah, but if you have like 1,000
That's
interviews,
true.
1,000 applications, 6 spots.
Alrighty, guys, enough great news, feeling good, feel good story. It is 12 o'clock. Let me know when you're set.
We're set.
We're set, all right, so we'll go live. The discussion today is on Pet Sematary. Where would the group like to start?
I wouldn't say an easy one, I think it's not easy, but I think the mom's
Yeah.
diagnosis is like, I feel pretty well, I don't wanna assume straightforward, but I think she has PTSD. And it's like manifesting through a lot of flashbacks, general anxiety.
All right, so observed anxiety in mom. Certainly editing through flashbacks. What if we were able to actually have her seated here today and she did present with a chief complaint of anxiety? So very generic chief complaint, very common chief complaint, even in the primary care clinics. And she provided information reliably that there are no flashbacks. So we're going to re-edit this script.
Okay.
There are no nightmares. There is no hypervigilance. Right? There is no exaggerated startle response. And no doubt, I don't avoid people or places. You do inquire through the comprehensive psychiatric evaluation, and it is revealed that she has the history that she does. Right? How might that change your original diagnosis?
Definitely less concrete because it's not as, I feel like PTSD is often like you have this event that's, oh, here are all the specific ways in which it manifests in my life, but I do think the anxiety is still, from such a young age experiencing something like that, it's hard to fully say that it's not, I think that her anxiety could still be linked to the event.
Could be. And let's say she allows you and she gives you that temporal relationship, which confirms or strengthens your thought. So you ask, and reliably she again tells you no nightmares, no flashbacks, no hypervigilance, no exaggerated startle, and no, I don't avoid people and places.
Can we ask about nightmares as well? Like,
A physical alteration with the other criteria, like, so, are they saying, sweating, if he thinks about it?
No, Doc, I saw a psychiatrist, really great one too, in New Brunswick, and I was diagnosed with panic. Now what? The single best answer here, you allow me to manipulate you, so cut it out. It's still PTSD. Right. This is much more clinical, Pearl, than it is preparing you for your shelf exam. On shelf exams, on standardized exams, you're going to get nightmares, flashbacks, hypervigilance, exaggerated startle, avoidance. However, the way the DSM is constructed with those 3 or 4 criteria sets, requiring only 1 or 2 from each, you can have and meet full criteria, 1 or 2 from each, and there is 0 negative predictive value in those more characteristic criteria that we all think of when we hear PTSD. So if someone in your clinical practice presents like this and reliably tells you no to all the above, there are remaining symptoms within each of those criteria sets. Right? Kind of gave me away a little bit by saying panic or panic-like symptoms, otherwise referred to as physiologic reactivity, which of course our patients would never say. But they will tell you that they've been previously diagnosed with panic, or doc, my panic is worse. That physiologic response is actually a PTSD criteria. All right, so again, clinical Pearl, always keep PTSD, especially when you get the history of trauma, and especially when you have that temporal relationship built in for you. Don't waver from it just because those more common signs are absent. Okay. So what are some of the other, I don't want to say they're uncommon, but maybe those other signs that we don't ordinarily think about when we hear about PTSD? And the the cue or the clue is that they are actually symptoms that overlap with other mental disorders, panic being the first example. What are some others?
Panic attacks?
Hmm?
Like a panic attack.
That's definitely one of them, no doubt about it. And again, that might be something you elicit during a psychiatric evaluation, or the patient offers you as part of their past psychiatric history, albeit perhaps misdiagnosed. What are some other examples?
Negative arousal, so like not feeling fully happy, not being able to cry when you're sad.
Doc, that's it, I was diagnosed with depression. Others?
Just generalized anxiety.
Anxiety, definitely. That'll be the chief complaint. But again, it could be generalized, but yeah.
Is there any element, this might be wrong, but is there any element of psychosis with like these flashbacks and these nightmares?
So there's two. Not necessarily the nightmares or flashbacks, it's a different subset. But individuals with this condition can have intrusive thoughts. So they can either present, if there's some insight, doc, my OCD is worse. So now you have OCD, panic, major depression, and a history of trauma, you gotta put that all together. Okay. But if the individual is lacking insight, their obsessive or intrusive thoughts may actually manifest through voices, right? So if the insight is at a point where they don't even recognize the thoughts to be a product of their own mind, they can report that they're actually coming from outside of my head and present as if auditory hallucinations. Of course, in terms of psychotic symptoms, hypervigilance similarly can be misinterpreted as paranoia, right? But not necessarily paranoid delusion, which again you'll have to tease away. Anhedonia is a diagnostic criterion built into PTSD as well, right? It's part of the negative cognitions, or along with, right? And of course, it can be misdiagnosed not only as a depressive episode, right, anhedonia, but also as a negative symptom of schizophrenia or psychosis. So be careful, because if you put that together and think that it might be a negative symptom, you might pair it with the paranoia / hypervigilance or the auditory hallucination / intrusive thoughts. And all of a sudden you have schizoaffective disorder, right? Especially when you think of other aspects of this condition, the affective part being the flattened mood and flattened affect.
Sometimes too, we'll see people been diagnosed with ADHD, but it's actually like they just start being impulsive and couldn't sit still after a trauma. So sometimes those two get kind of confusing.
Yeah, and of course, I'm guessing at the literature here, but my gut says that that's even more prevalent with it being age dependent. Right.
Can it also have like agitation and mood swings, like
Yes.
with triggers, and then how do you differentiate it with like a borderline?
Well, sometimes you don't, because there are some clinicians that believe you're talking about the same illness.
It's
Right.
trauma induced.
Yeah, trauma-induced is a third variable. We think the way the current literature is formatted, if you will, we think of these as highly co-occurring or comorbid,
Right.
but there are theorists that conceptualize that actually being the same illness. Right? And if we focus on character traits, we're going to call it borderline. If we focus on it as an anxiety disorder, we're probably going to call it post-traumatic stress disorder, but irrespective of the label, we're talking about the same exact thing with the same exact etiology or the etiologic event. In terms of what we just discussed and reviewed, if you were to rewatch this movie and focus primarily and only on mom, would you think you'd find additional signs supporting PTSD other than the nightmares and the anxiety? Anything jump off the screen at you?
Well, she hears the sounds, or I don't know if that's included in the nightmares, but she hears that too.
Yeah, again, might that be indicative of auditory hallucinations / intrusive thoughts, really, right, that continuum? Now, she's high functioning, my gut suggest, I mean, I would think that she would more likely present with intrusive thoughts than auditory hallucination, because she is high functioning, but we have to always, again, keep that in mind. All right, so, we think she has post-traumatic stress disorder. She presents to you, you confirm the diagnosis, and now we're ready to provide a treatment plan in the sequel to Pet Sematary. What are some of these? SSRIs, right?
And talk therapy,
Right, psychotherapy, right?
trauma-based therapy.
Yep.
CBT.
Yeah, right.
Chris
So,
Dawson.
a variant or specific CBT. And while it is true, SSRIs, multiple SSRIs do have alternative indications. In post-traumatic stress disorder, on a shelf exam, you are 60-40, more likely to be asked what medication to avoid than which one would you start. So you're not wrong in saying the SSRI, but the greater likelihood is that you're going to be asked which of the following medications in the literature has been found to worsen the course of post-traumatic stress disorder, and your single best answer is benzodiazepines. And that includes that around the time of the trauma because of the way memories are encoded.
It like induces like the amnesia
Yeah.
effect, so you'll have like physical symptoms, but maybe not remember why. Like maybe physical manifestations of trauma, but you don't remember why.
Well, I think generally speaking, the closer you are to the trauma, if you're taking a benzodiazepine, the action of the benzodiazepine is such that you are not going to, you're going to have a more difficult time encoding those memories, which means that they might be fractured in 5 or 10 or 15 years from now to a greater likelihood than if no benzodiazepine slash when compared to a control group. Right? And that's pretty consistent in literature. So again, likely to come up on a shelf exam. Pardon the pun, but final thoughts on post-traumatic stress disorder. Favorite movie about PTSD other than it's not on the shelf. Although if I were a question writer, definitely on the shelf. But favorite movie about PTSD other than Pet Sematary.
Our favorite, or are we guessing your favorite?
No.
I was like, I don't know.
I bet you though if I gave you 3 guesses, you'd get it. But I am actually asking your favorite movie about post-traumatic stress disorder other than Pet
I
Sematary.
definitely seen movies about PTSD now. I'm like, what
I know.
movies have I
Yeah.
ever watched?
Is
Yeah.
Memento about PTSD? Technically.
You could definitely make that argument. Really, dissociative amnesia probably is
Yeah,
the
yeah.
single best answer if we put Memento as a case vignette on the shelf. But we'll give that one an honorable mention.
Is it Iron Man 3?
It could be, I have to be honest with you, I haven't gotten as far as Iron Man.
The Room.
Oh, yeah.
Well, I mean, you have to remind me about the ending because I know she, spoilers, right, so plug your ear, leave the room. I know she escapes. That's a great movie, so I'm gonna say yes. I'm just trying to think, what we see, like 90%, 95% of the movie is the trauma.
Yeah.
I wanna see the sequel. But that's not a bad answer, that's a good answer.
I think the movie, she like, it's about halfway, they like get out, and like she
Yeah.
has a lot of
Yeah.
trauma
Yeah.
from it, and surprisingly, the son adapts much better back
But
to.
if it's right after, that makes it adjustment disorder technically, not PTSD, because at the time.
Yeah, we're getting acute stress disorder,
Or
yeah.
acute
So,
stress disorder.
we'll catch you on the technicality, but it's a good answer, that's a good. By the way, when we stop the stream, remind me about that, because I want to talk to you about that movie. Not live.
We're still sharing our favorite.
Yeah, why not?
So I can't think of any movies specifically about PTSD, but one movie, like, I don't know if you've seen The Da Vinci Code or anything with Robert Brown, like, I think the author and the main character is, whatever Tom Hanks plays, but he has PTSD after falling in a well as a child, so in the movie there's always periods where he's like in an enclosed space and has to breathe to then go solve the mystery. It's a feature in the movie, it is not at all the point, but it's a great film, I watch it at least twice a year. I love The Da Vinci Code.
Awesome.
Yeah.
Do you like Harry Potter has PTSD?
Why was I just
Oh my
thinking
God,
that?
He has
yeah.
nightmares, he has intrusive
Not
thoughts,
Wait,
he has
absolutely.
images.
Literally in my
Yeah.
brain.
Yeah.
Well, is there,
We lost
how
both his
long?
parents.
It's probably the movie I've ever seen.
All right. And I'm thinking, it's Robert L. I'm blanking on his name.
Robert Langdon?
Yeah.
Langdon?
Yeah,
Langdon,
yeah,
oh my God.
yeah.
And Dan Brown was the author.
Right.
I think the Hunger Games kind of stuff.
Oh, yeah.
PTSD by the end.
Yeah.
For sure.
All right, back to Pet Sematary. What other characters you want to tackle? Louis?
Lewis.
All right, observations?
Acute stress after his daughter died, because he really didn't have that many like symptoms per se prior to that, for the most part. But after that, I mean, his like nightmares, night visions of the boy he tried to save, like, were really prominent. If like we assume that the dead coming back to life is, if we don't know necessarily if that's real.
Let's go with in the direction that it is not real.
Sure. Then yeah, these hallucinations or delusional thinking became a lot more prominent too. But it was a recent event versus the wife's event was in childhood.
Mhm.
Differential could be like just like in the TR added like complicated grief syndrome.
Yeah.
Yeah.
Yeah, and I think if you're looking at two isolated events here, one, the death of a student, and due to flashbacks, probably acute stress disorder, then death of daughter, probably looking at least initially, bereavement, right? So I think if at or around the time, we did observe, bereavement is probably the single best answer. Clinically, we interchange this clinical term, this diagnosis, with grief. Grief is more the feeling, bereavement more the syndrome. And in either case, depending on which vocabulary word you choose, normal, right? Completely normal. However, both qualitatively and quantitatively, the individual can demonstrate signs that suggest that it is outside of a culturally sanctioned norm. And the DSM-5 built in a new diagnosis as of 2013 called persistent complex bereavement disorder, otherwise complicated grief, to capture this. Right? And we could certainly see signs of that here in this film. But then there's even more, because individuals with persistent complex bereavement disorder have increased risk for developing a major depressive episode and therefore major depressive disorder. And I suggest that's what's happening here as well. And then we see some evidence of psychosis, meaning that his NDD episode is likely severe with psychotic features. So we see a full continuum, albeit rather quickly. Starting with what we would consider to be a normal grief reaction, and then through that intermediate persisting complex bereavement disorder to MDD, severe with psychotic features. Now, let's talk a little bit about the psychotic features. Describe to me, if you want to step outside of the supernatural and or instead on call and solve this case, what aspects, how would you relate the psychosis to the attending on call?
Patients come in saying that his dead cat is alive and walking around the house. First is the first thing.
It gets worse, doesn't it?
Yeah, I get what. Then patient comes in and says that he's having auditory visual, and I guess tactile as well of his daughter, his dead daughter.
And the student.
Oh, and the dead student, dead cat, and the daughter, walking around his house, interacting with him, causing him stress.
He's sleepwalking too.
Let's get to the sleepwalking in just a little bit. I think that's going to be a co-occurring diagnosis. But for aspects of the psychosis that likely are incorporated into a major depressive episode, what if upon further questioning, especially with his family, we learn that his daughter is not dead? What is the single best diagnosis?
Told us the name of the
Right,
name
right,
of it
probably,
a few weeks ago, but I can't remember.
He's-
That's what it's
Someone's
right?
name.
So you're prepped for a multiple choice exam.
Yeah, I
Yeah.
can recognize it. It's like CO or
Right.
something.
Perfect.
What is
Good.
it?
I don't know how to pronounce it. though.
Qatar.
Qatar, yeah.
Right, the Walking Dead syndrome.
Yes.
So I mean, really any zombie film can be used as a metaphor for the Qatar delusion, and that is the false belief that someone, perhaps even yourself, is dead or dying in some way. Right. So if the script were rewritten where we have this character presumed to be dead, and then through collateral information, we have information that actually goes against the self-report. Patient's very much alive, but the character, our patient, persists with the belief that they are dead. That's hard. How does that differ from Capgras?
I think everyone's an imposter.
Yeah, it's the imposter syndrome, right? That's the thing, right? That's any alien film in which there's assimilation, right? You're not real. You think you're not a medical student. You're an imposter, right? And then how do both of them differ from Fragoli, the Fragoli delusion? Fragoli is the shapeshifter syndrome, the false belief or the delusional belief that a person can intermetamorphosize, that is, change their appearance. So you're not an imposter, but you are so-and-so and you just change your appearance. Right, that's the Matrix. Neo has the Fragoli delusion of those agents being able to shapeshift. All right, so bereavement or normal grief reaction, persisting complex bereavement disorder, MDD with psychotic features. So Lewis presents to you now with evidence of major depression with psychosis. How do we differentiate that this is not schizoaffective disorder?
Was he having the psychotic features before the mood symptoms?
Exactly right, time frames, right? Give me evidence of one without the other, and I'll tell you the primary underlying disorder. Right? So individuals with schizoaffective will, during the course of their illness, demonstrate psychosis in the absence of any affective or mood symptoms. And that's the direct opposite of a primary mood disorder with psychotic features. So we have to go back to the prequel.
Comes out like.
All right, we're going to establish this as a primary mood disorder. We're going to call this major depression. And we're going to look at the etiology of the depression again as the death of disorder. That said, I still want to talk about the primary sleep disorder as well. But that said, what was it do for him?
Greek counseling?
Psychotherapy?
Talk therapy?
Yeah.
Maybe he's not inpatient also leadership, because he's also drugging his neighbors,
Yeah.
harmed others.
And if his daughter's alive, he has HI, because he
Yeah.
tries to like kill her at the end.
Right, especially if we learn that she's very much alive.
If she's alive,
Yeah,
yeah.
so not only are we talking about what biopsychosocial treatment plan we'd like to employ, but we're also talking about the level of care in which we're going to employ it, right? And that's a major part of our clinical skills verification exercise for our residents. They have to pass 3 by the end of their PGY2 to be board eligible. And as part of their discussion, they not only have to put together and formulate a biopsychosocial treatment plan, but they have to actually remember to discuss where they would like it implemented. And in this case, I think that inpatient psychiatric hospitalization is medically necessary. So now you're the inpatient doc. You are going to order or provide psychotherapy. What else are you going to do? By the way, a quick tangent. If we had decided this was a primary psychotic disorder, what is the only form of psychotherapy that has empirical evidence of improving outcomes in schizophrenia? Psychotherapy.
Oh.
Family therapy. Family therapy to diffuse the stress that might lend to exacerbations of the underlying psychotic illness. Right? So it comes up in exams all the time. Family therapy has the strongest empirical evidence in schizophrenia. Right? That's not the case here. This is a primary mood disorder. We're going to provide psychotherapy. And in addition, what other parts of the biopsychosocial treatment plan should we discuss? So you're gonna order psychotherapy and discharge it?
Medication,
Huh?
Medication.
Thank you. What do you think?
Could be an SSRI.
and an antipsychotic.
Yeah.
So let's say,
No, actually, I was going to say something, but then I realized I was thinking about a different type of diagnosis.
okay, let's say we went with the SSRI or antidepressant only. What percentage of people with this very condition, with Lewis's very condition and diagnosis, improve with SSRI or antidepressant therapy only? Give me one guess. 30. Okay. So let's say we're not going to do that, but let's go conservatively with the antipsychotic only. Now what percentage are going to improve with antipsychotic therapy only? 30. So of course, we're going to do both. We're going to do both, and now we're looking at a 70%.
Wow.
Any other considerations?
Was it like atypical antipsychotic as opposed to like first gen, just consider safety profile? He seems young and healthy. I don't think I'd be worried about like any sort of like metabolic concerns. I don't think he needs like clozapine or anything like that because he's not actively suicidal. So maybe like aripiprazole or like Luceridone or Ziprazole. I don't think I said that right. Maybe one of those. And then for an SSRI, maybe like Lexapro.
So less med-to-med interaction with escitalopram or Lexapro, that's fine. And a lot of this specific decision-making will really be patient-centric. And again, we're looking at about a 70% response rate. Any other considerations here for treatment?
I think just like monitoring for any like breakthrough mania symptoms, given that we don't know much history about if he's ever had a manic episode.
What if I said that there's another treatment that we probably should discuss and then discuss with our patient because we know it confers a 90% success rate in this scenario? ECT. Yeah. So even if we know that he's going to say no, and we should know that, but hypothetically, if we feel strongly that he is going to say no, to provide him medications that are going to be less effective, 70% versus 90, with more side effect, is malpractice. Right? That's not a true informed consent. Right? So alternatives to care are a necessary part of the informed consent process, and you cannot skip an alternative that is better with less side effects. So electroconvulsive therapy has to be discussed here. What do we think, or what do we make of his potential sleep disorder? What do we want to do for it?
Is he melatonin? So he's sleepwalking, it's a non.
Right.
Mm-hmm.
It's a non-REM
Yeah.
sleep arousal disorder.
Yeah.
Right.
So, melatonin.
Yeah.
Agonists.
Unfortunately, yeah, there's not melatonin or melatonin. There's really no abundant evidence that pharmacotherapy is going to be effective here. And so more behavioral.
CBTI.
Oh, yeah. Like safety measures in the house, make
Yes.
sure you're not doing like, anything, making sure there isn't nothing you like accidentally either walk into or use to hurt himself immediately, or hurt himself or others immediately. Talking about it with your wife.
Again, it could come up on exams, but if you were asked what the other non-REM sleep arousal disorder is, yeah, sleep terror disorder, sleepwalking are the two primary examples.
I have a question. So, if it's a non-REM condition, you usually don't remember what's going on, but he always remembers. Like, is it just because, sleepwalking kind of, you're doing all the motor aspects? Because REM is like, you're atonic, like you're not moving around. So is that kind of why it trumps it as a non-REM condition?
Anybody? I forgot that he remembered. Thank you.
And he doesn't do anything about his dreams, but so I don't know how well he's remembering that.
And by the way, because of this now getting a little complicated, perhaps even prior to this evidence, maybe a polysomnography.
Yeah.
But in either case, we have a problem, because we're gonna assume that the Hollywood producer didn't screw up here, because they did. Right, they should have had this screenplay proofread by a Robert Johnson medical student. So how do we kind of undo this mistake? AKA broaden our differential diagnosis. What is another diagnostic consideration?
Nightmare disorder.
Well-
Actually, okay, no.
Like derealizing, or like actually kind of awake, like you feel like it's really him.
Could be, right? It could definitely be a non-sleep state. So we might be just wrong thinking this is a sleep disorder. It could be non-sleep, it could be delirium, it could be dissociative episode.
What is the name of it when it's like you forget your entire identity and it's like people?
Yeah, dissociative fugue.
State.
Yeah, so that would be dissociative amnesia with fugue. By the way, the other movie we discussed that casts dissociative amnesia with fugue is Sinister, which also has a character with night terror disorder or sleep terror disorder. So there's a little overlap there in terms of diagnoses from these two films, Sinister and Pet Sematary. But I digress. The other condition I want you to consider here is REM sleep behavior disorder. Right? These are individuals who are in REM, but maintain muscle tonicity. And so there's like a 5% variance in the US population. This is very dangerous because people tend to act out their dreams. And this is, again, this is headed towards a polysomnography as a result. So going now away from non-REM sleep arousal disorder, specifically sleepwalking, to a REM sleep behavior disorder, which will be confirmed upon polysomnography. All right. If he rules in here, what are some diagnostic considerations?
Maybe it was right on that.
Mhm.
REM.
Yeah. And let's say we accelerated this to, again, inform the writer-producer and cast this character instead of, I guess he's in his 50s? Maybe late 60s.
Are you saying like he's older in this situation?
Oh.
In my situation.
I think it's about Parkinson's.
Yeah. Yeah. So he's gonna be going for an MRI or head scan. And we're gonna be concerned that this might be a forerunner to Parkinson's disease, a synucleodystrophy. All right, anything else for Lewis?
I liked him better as a main character than the main guy in Sinister. Considering they're both families that move to rural places in which the wife is, I think he's just a much better person.
Isn't he a doctor?
Yeah, I'm not biased for that.
Oh, no, not consciously anyway.
No. They were saying, for an ER doctor,
Yeah.
he was like dressed in like a suit every day, and I was like, I feel like everyone wears scrubs all the time. Much better, generally. 100%. Even when he was hiding stuff from his wife, it wasn't as bad.
A little less countertransference on your part?
Yeah.
All right, so we're past the bottom of the hour. Any other characters you'd like to focus on before we stop?
Judd.
Judd? All right, what's going on with Judd?
Judd, some complex grief. Well, yeah, I guess complex grief, because it came to the point where he like resurrected his wife at some point and then had to kill her again, and I think he's not really working through that as best he could.
Yeah, we were kind of shocked at how many times he did this, and he was still surprised at the result.
Yeah.
Because we were like, okay, maybe if he just resurrected his dog as a kid, and
Yeah.
he thought maybe it'd be better this time with the cat, fine. But he already knew, like, he did it with his dog, he did it with his wife, also turned out bad.
Yeah.
And now he's having, Lewis do it too. We were a little bit is he delusional, he thinks it'll work? Is he purposely forgetting, like, how it worked the last few
Did
times?
someone say he was like, did you say it's insanity? He's doing something multiple times.
Yeah,
a day,
it was
or
what we were
something?
saying. Yeah.
So, I mean, his psychopathology appears to parallel that of Lewis's in terms of starting out with a normal grief reaction and then going through that continuum. And I don't know if this is really true, but in one context, Lewis, we said that this was likely a primary mood disorder with co-occurring psychotic symptoms, hence the single best answer of major depressive disorder with psychotic features. Judd has a very similar course, and given your observation about his repetitively doing this, and maybe there's a baseline psychosis, I wonder if his is, fortunately for us, in terms of a teaching model, schizoaffective disorder. Right? So whether we say it's insanity, whether we say it's psychosis, having this case, which appears to parallel, be that other diagnosis that on shelf exams medical students always have to compare and contrast. These two characters, I think, allow for that. Now, I don't really know if he truly rules in for schizoaffective, but the conversation's definitely there due to the observation that, yeah, this seems quite repetitive and.
We've got continuous delusion that this is gonna work.
Yeah.
It's never
Yeah.
changing.
Yeah. Now, again, if we were to have informed the script writer, we would want to make sure that affective symptoms were completely absent in this character for the duration of the quote-unquote case study, i.e. movie, right? Because that would really be kind of cool from an educational perspective, right? But it's worth a consideration.
Gotta watch the prequel.
Yeah.
The prequel focuses on Judd. and his
Yeah, if anybody
childhood.
listening to us on live stream now is not like buying tickets for this prequel.
Yeah, it's a show.
Paramount
Streaming,
Plus is
yeah.
I mean, it's time to get your Paramount.
Subscribe to Paramount.
Yeah.
That's all I had.
Should get some commissions.
Really.
All right, so anything else for Judd? Let's say you engaged him in psychotherapy. So again, I think whether we call it schizoaffective or not, he's going to have a very similar biopsychosocial treatment plan. There's therapy, which may include family therapy now. But, well, if it's a family, but maybe not family therapy. But otherwise, a combination of antipsychotics and antidepressants, and let's discuss the option, the alternative of ECT as well. So very similar. Let's say he comes to you with psychotherapy, and your initial focus in your therapy session is this repetitive nature, and he's cognitively intact. So we're going to kind of step outside of this idea of this being a primary psychotic disorder and employ therapy beyond just family therapy. This is individual therapy. What might be something, a topic, an issue, that you think is uncoverable, given the nature of that observation that doesn't seem to get it? You think he'd stop after his wife or the cat?
I have two thoughts. One is like, is this a compulsion that he's like fulfilling by having to repeat this over and over again? Maybe like some OCD tendencies. The other thought is there some kind of like secondary gain that he's getting from this? Like, is he feeling like he has power over those he resurrects, or is there other stuff going on?
Is it like a defense mechanism? Like, is there some repression going on?
Or like, is undoing appropriate in this?
Is it defense?
Yeah.
Yeah. Yeah, I think, and I agree with all the above. I mean, so number one, again, in the hypothetical rewatch, do we see any other compulsive behaviors or intrusive thoughts that might lend to strengthening the idea or hypothesis that this is part of an OCD spectrum? Again, looking at who gave his hoarding. I don't remember what the house looked like.
It's okay. Yeah, I mean, a little bit like a well-loved house, a lot of little like momentums of like little photos and things like that.
Right.
He's like always chopping wood, but I assumed it was for
Fire.
yeah, like reasonable purposes. But maybe he like does it all the time, every day, and has to be like a certain amount of time. Like I don't know. I only see him a couple times doing that.
The only other thing I could think of in terms of what, and again, I wouldn't sort of consider this the first or initial therapy session, but there might be issues pertaining to death and dying in this character, since he does seem, maybe as a defense, to employ undoing. What's that about? And what is your faith, spirituality, your belief in the afterlife? He's at the age where Ericksonian theory would suggest that he's struggling with potential ego integrity versus despair. So other things to consider as well. All right, final thoughts.
I do just think it's interesting, sort of not related to anyone in particular, but throughout the whole film, and we were like, kind of from the moment it started, being like, oh, like, he's gonna have to kill his daughter, like, he's gonna bring her back. And there's a lot of talk about, like, how you have to undo it if you do it, but it never actually happens, right? Like, no one ever has to, like, actually undo what they've done here, which I don't know, I just thought it was interesting.
Also, if he had either not done his star or undone Church or whatever, if he had actually like killed Church, none of them would be
None
dead.
of them would have
Yeah.
done it.
Yeah.
Yeah. Yeah, that's true.
Like they wouldn't have run into the street. They wouldn't have hit by
Right.
cars.
Mhm.
Like
Yeah.
the rest wouldn't have happened.
Yeah.
Right.
It's like, you have to, like, resurrect at least one thing, like, leave it at church and don't try and do it
Yeah.
again.
Yeah.
But you're right. They don't ever actually like undo
Yeah.
any of it. It just
Mhm.
all stays.
But
That was
but
interesting.
isn't that a metaphor for OCD though? I mean, people will compulsively hand wash, and it's not like once you hand wash a certain amount of times, then you don't feel the compulsion anymore. Right, so there's a parallel to what the real struggle is when individuals maladaptively employ undoing in the context of OCD. All right, we'll leave it there. Thank you. Any final questions?